very warm welcome.
Now, can everyone hear me today? Yes. Good afternoon. Thank you for all coming today. This session is going to be pretty jam-packed, so I hope your attention span is still up today. I'm Tim Keeley. I work in Sydney in Bondi Junction with 4 clinics. I've been in this game for about 12 years, and the entire time that I've been training, I've been doing physio and training, I've been working with fitness professionals. So every place I've worked has either been a gym or a rugby club or anywhere that involves personal trainers. And what I've sort of come to the conclusion is that it's not just the fact, it's not really the personal trainer causing an injury, it's the injuries that happen during personal training. And usually the causes and the predisposing factors, which we'll talk about today, happen outside of the control of the personal trainer. So today is a lot about learning and understanding what are the common injuries that we see as physios in gyms and with people who are doing personal training. Trying to get you guys to really get a good emphasis on what the injury is and understanding it well, because if you've got someone who's got who's a client that has major problems, you cannot exercise them very well if you don't know how the injury happens, why it happens, and what the physio is doing in their rehab. So if you can start understanding those things, which I'm going to help you with today, you're going to be so much better with dealing with all your clients who've got these sort of problems. So let's just run through. Hopefully my little clicker works today. It's a bit temperamental. There we go. 10 injuries I've come down to. Now, I went through with my colleagues before in the last few weeks, making sure that they were happy with their 10 injuries that I chose. Don't be confused with sports injuries. Okay, these injuries that you'll see on your handouts, and by the way, if you haven't got a handout, I'll show you a link on our site, you can download it. Not to be confused with sports injuries, like rolling your ankle or tearing your anterior cruciate ligament is not going to be in here, because that's more of a sport injury. We're dealing with injuries that happen during personal training sessions, not necessarily caused by personal training sessions, but during their sessions. And I'll go through with each one 3 things. How it happened, okay, what goes in the process of happening. A lot of them, there's this circle, I call a circle of cause or a circle of occurrence, where one thing leads to the other, and then if it keeps happening, it keeps going around the chain again. Second thing, nutting out exact causes and technique problems, predisposing factors that person has, or why they're getting this issue, which you need to be aware of. So when you are training them, someone has had an old injury, or you're seeing something that's going wrong, you know how to address it. And the last one with each one is what you guys are going to do to help someone like me with the physio. So I need someone who, I need personal trainers understanding what we do and then taking on board our exercises into their gym program, modifying their gym program to help these people along, and working out little things that you can do to prevent it A, recurring, or B, ever happening. All right? So, there it is. First one. Now try not to look at your sheets too much. I'd rather you not look at me. Rather look at the visual up here. Don't worry about your sheets. If you've got anything, just write it on the sheet. Weightlifter's shoulder. Has anyone heard of weightlifter's shoulder before at all? Okay. Weightlifter's shoulder is a acromioclavicular degeneration and arthritis. Pretty simple stuff. It'll be pain right here. Not the rotator cuff type pain, but pain right there. And they'll feel tender on their AC joint. Okay, so get in there and that's a bit sore. A lot of the time you'll see people coming off the bench and they'll give it this one and they'll sort of try and rub it out and that feels a bit sore. It takes a long time for that pain to get to that point. Okay, so there's been a lot of wear and tear going up to actually get a painful shoulder. If you've got someone who's got tenderness in their AC joint, not from falling off a bike and dislocating their acromioclavicular joint, but actually from doing gym training, there's been a lot of wear and tear to get up that process. So just in a nutshell, if you're doing a lot of overhead lifting, a lot of heavy bench pressing, this can lead to it. And we'll go through the causes in a minute. But it starts off with pain inflammation. And when you get pain inflammation in that joint, the joint becomes a little bit unstable. Fluid inside a joint that shouldn't be there, muscles tend to switch off, ligaments tend to start getting lax, the whole thing starts becoming unstable. When that happens, it triggers that pain, and that messaging triggers your scapular muscles to start switching off. So what was a good form, if you're starting to get pain, will now turn into a poorer form because your scapula is not moving correctly when you press or push upwards. Over a period of time, that's when that wear and tear, arthritis, starts kicking in. If they keep loading up that joint, they actually start causing degeneration. If you know your anatomy very well, underneath that acromioclavicular joint is your rotator cuffs, just sitting right underneath it. Now, if you're starting to get impingement underneath that, it'll give you even more problems. They'll get really sore right underneath as soon as they move. So that's your process, all right? Get this right. Heavy bench press is probably the number one cause. Okay, heavy bench press, and we'll show you why in a minute. Most of the time it's heavy but with incorrect technique. But the problem about bench press is it sort of generates a bit of incorrect technique from the start because of the way the bench is set up, and if you get blocked in your scapula, and we'll show that with Michelle in a minute. But also repeated lifting above the shoulder. So not just bench press, but anyone who lifts above the shoulder is likely to wear and tear that. People like that you've got to think about. If you're training someone with doing a lot of upper body work and they do a lot of upper body work in their occupation, maybe they're a painter, maybe they're a landscaper, okay, that's adding to the problem. It's maybe not just the personal training issue. It might be the fact that they're already doing a lot of wear and tear in their shoulders anyway, and they're adding to it with the weights that they're doing. Michelle, if you want to jump up. I'll show you what I mean by this technique. If you've got someone on a bench press, now you can't escape this. So I'm not saying don't do heavy bench press, okay? You're not going to get big pecs if you don't. But if someone's getting pain there, this is something you're going to have to cut out. So when they come down, a lot of the reason why people will get a shearing movement or wear and tear in their AC joint is when they come down to 90 degrees, at that point there, the scapula doesn't really move any further. Okay, you don't get any much more retraction in the scapula. If they go lower, what they're going to get is a shearing force through that AC joint, okay, at that point. And so lots of heavy weight here. Remember, the arm is only connected structurally, skeletally, to the body by that little AC joint. That tiny little, you can push it up again if you like. This little thing here is the only way that scapula is connected to the clavicle, and therefore your arm. The rest of it's muscle suspension. So no matter how strong you are, it's still a shearing force, an open chain shearing force going straight down through there. Okay, a lot of people it's fine. People with pain, this sort of thing is usually one of the causes. Okay, so how are we going to fix that? People, don't go below 90. You've probably heard that before. You can go below 90 with a lot of things. Okay, heavy bench press. A lot of people do go below 90. People with this sort of problem or starting to get sore in the shoulder, you can't go below 90 anymore. They've got too much wear and tear. Remember, this is not just a little injury that will go away like a muscle tear. It's permanent degenerative change. So they do not do bench below 90 anymore. They can do bench. Their weight will have to come lighter, but can't go below 90 because the forces are too great. And you've got to try and encourage retraction. If they can't get it on a bench, they're going to have to go to a Swiss ball or something to actually get that proper movement back. Because if you imagine if she comes down, drop down for me, Michelle, and she actually retracts, she can actually go further than zero because you're actually getting that extension there. So a better thing would be on a Swiss ball. She probably can go below 90 because she's getting a nice retraction, but on a bench, you're not getting that retraction. Does that make sense? Thanks, Michelle. So, other things to do with this as well, it's an open chain movement, so change it to a closed chain. Press-ups, obviously. And you want to do heavier press-ups, put some weights on their shoulders. Make sure they're doing their protraction when they're doing their press-ups. And if you want to know, is this person getting it, push down their AC joint, give it some stick. And if that's really sore compared to the other side, you know there's some sort of wear and tear going on there, and you're going to have to start changing some things, maybe seek some referral to a physio. Because if this blows out, and a lot of times we see this blow out, they'll come in and it's red, raw and sore, it's 3 to 9 months recovery. These people take a very, very, very long time to get back to what they were doing. And they do have to change their program quite a bit. Okay. Same sort of topic, pec and bicep tears. I've grouped these together because they're pretty similar. There's 3 times that these muscles are going to tear. Intramuscular, so within the muscle, okay, muscle. Musculotendinous, between the muscle and the tendon junction point, and then between the tendon and the bone. most of the time it happens between the muscle and the tendon. If you look in this picture here, right there, can you see how that pec is a bit missing? You see that? So some of that pec muscle is ripped away from its tendon attachment. Most common cause. Most common cause for people who are doing heavy weights, powerlifting, that sort of thing, with inflexibility issues. There's no real stats on steroid use versus tearing and tearing, but a lot of the time we get people coming in who are massive beyond normalness, and they're the people with these problems. Same with the bicep. Tearing from that bicep tendon, it's a nightmare. But basically the surgeons can't really repair that very well. You'll see also bicep tears in older generation people. Have you ever seen like a grandpa or someone who's got the bicep muscle fallen down and it's sitting down here in a little ball? And that's just from wear and tear. There might have been a carpenter or something in their age, and then over time it wears and tears and actually tears away. My friend has had a bicep tear and a pec tear, and it's come out of the bone, and that just goes like a gunshot. Most of the studies on these ones, the person's doing on an eccentric phase. So a fly or a bench press, but on the eccentric phase, and it fails. Okay, not the concentric phase. It's usually on the way down. These people you've got to watch. They're doing a lot of bench press, that sort of thing, and usually their rotator cuff or their joint stability is not so good. So the demand and the shearing forces through the joint is high. The whole thing starts fading, fatiguing. But biggest number one thing, too much weight and poor form. Now, with the bicep one, if you see people and they're doing bicep curls like this, that's probably why they're the cause. Because they're not getting the support from their scapula, if they're not sitting back into this position. Okay? If they're not doing that position there, their rotator cuff won't work in that position either very well. So the load through that front bicep tendon is very, very high when you get someone like this. The classic is that preacher curl, where they just are forced into that position. They just cannot hold it back. Or they can hold it back, but the weight's too heavy, so it just pulls them forward. And what they don't know is that loads up your tendon issue. Okay? So if you see people doing that, they're the ones that are more likely to get tears. And of course, your classic things like lack of recovery. Remember, overuse is usually a lack of recovery. They're not resting enough. Be careful of your hypermobile people too. So if you want to jump up, Michelle. People who are hypermobile, okay, if they go beyond excessive ranges, say they're doing a fly, so you go forward for me, Michelle. Pull forward. No, pull forward. That's it, pull forward. Way you go. Ooh, stronger than I thought. Okay, when she comes back, remember eccentric phase, hypermobile people have less awareness about where they should stop, and they tend to go all the way back here and then try and pull forward, and that's where it'll tear through the bicep or the pec. Okay, both regions at this point here. Now, why? Because when a muscle's in its outer range, it's weaker. Okay, it's harder to pull from here than it is from here. All right, so just be careful of these people. These people might have, you've got heaps of range, but that's not necessarily a good thing. So they need to learn where to stop because they don't know where to stop. So just be careful of those people. Yeah. So you should always have a stand for Michelle. You should always try and re-educate those people when they're bicycles to actually set their scapula back. You know, it doesn't matter if you hold it back, that sort of thing. That's fine. They really shouldn't be trying to retract and hold there. That's not a good thing. They need to be setting their shoulder. See how she pulled it back a bit, and then I need to just re-educate her that it's not actually that far back, just neutral. Okay. If you turn her face this way, when she pulls back, pull right back, retraction. That's not setting a scapula. Setting a scapula is getting it into neutral and making sure they don't wing. And if they're winging, if that's sitting out like this, you need to just see how she wants to do that. You need to guide them, pull that scapula out of position, and tell them to hold it, and then they do their bicep curl in that position. Okay. Less demand on the bicep. Okay. Scap setting. Again, if you've got a tear, remember, these tears are going to be a localized point of tenderness. They're not going to be like, oh, geez, my whole pec, so sore. That's your DOMS. Localized point of tenderness is going to be your tear. They need to rest. they need exercise through the physio, then you need to get into that physio clinic and see what they're doing, work out what you can do, that sort of thing. They'll start closed chain, they'll build up to open chain again. The people who have a full-on tendon rupture, the surgeon says no pressing for 6 months. That's a very, very long time for not to be doing any pressing. In fact, they're not allowed to do any abduction work, so not allowed to pull in for about 3 months. So they have to keep their arm like this while it heals up. It's a bit of a nightmare. And you've got to understand, if you've had people or friends or clients that have got these sort of problems, you've got to be very careful that this doesn't happen again. Because usually it's not quite always the same. And just educate them a little bit more. If they're getting tears and things like that, they're doing something wrong. Their training's wrong, their rest is wrong, maybe it's their technique, maybe they're too heavy, maybe they're trying too much, that sort of thing. Get them stretching too. A lot of people will tear because they are too inflexible. All right. The wry neck. Is anyone waking up like this? Yeah? So how are you doing this morning? Yeah, good. Yeah. And you don't know why? It's like, oh, it's sore in here, and then it's down here, and you're trying to get the tennis ball in there, and oh. And after a while it comes right, but then it recurs again. Okay? 3 or 4 weeks later, oh shit, it's back again. You know, you brush your hair, and oh God, there it is again. Now, a lot of people think, oh, it's a neck problem, oh, it's the way I'm sleeping, oh, I don't know, you know, not so sure. A lot of the time, training is to blame, and their lifestyle is to blame. Okay? And the biggest one, number one cause in this is people sitting with a thoracic kyphosis. Do you want to jump up here? They sit down all day like that. Look at me. Look at me. Like that. Yeah? Looking at their screen. Now, being like that for 8 hours and then going to the gym, they won't hold perfect form. Okay? Or if they try to, they're very stiff and they create problems. Okay? So it's not necessarily a personal training form. You've got to think outside the box with this one. It's probably what they're doing like that all day, and you've got to re-educate them in their sitting. It's your job, not just my job, it's your job as well. Because if they come in like that, well, they've been like that all day, and then you train them without telling them what they should be doing during the day, then you're sort of part of the cause. So these people, again, if these people train like this, which a lot of them do, because if they're so stiff here and they can't extend properly, then they'll get to this point. Now, when they're doing shoulder press, they're still in that position. So then the work rate of their upper traps and their neck muscles are really going for it. The shearing forces through the spine is really high. Okay? So these people, one, you need to correct them and get them in the right position, but also tell them what they should be doing when they're sitting, how important that is. And if they don't believe you, get a mirror there and show them how bad their form is. Yeah? So they need to be upright here, but also they need to think about the neck. A lot of the time, don't get them try and pull their head back because they'll tilt it back. I want you to think long at the back of the neck when they draw their chin in. So they're in that position. Teach them that, because then if they learn that when they're training, hopefully they'll adopt that when they sit down, and then you can get them doing that during the day. Yep, good one. So with these sort of people, they get a positional fault problem, which strains all the ligaments through their cervical spine. Their muscles start working to try and hold their neck back, and so they're overloading. It starts causing pain, inflammation. When that gets to a point of enough pain, it'll start referring into muscle. So you'll get pain going from the neck down into your traps or down into your rhomboids, which feels like the problem's down there. Yeah? And what that does is causes a spasm. Now, they usually are fine during training. It's like, oh, it's a bit sore. Yeah, it's a bit funny. They go do some pressing, a lot of up-trap work, a lot of blood flow, a lot of adrenaline. They loosen up, they feel great, but they're doing heaps of straining and shearing. They're winding up those trigger points, but they're fine so far. Then they go to bed, inflammation kicks in, they wake up like that. Okay? So if they're starting to get niggles like this, you've got to watch their form and maybe take away some of their upper body work. Get their neck loosened up. This is what they look like. Get their neck loosened up. Okay, so from the physio to get it and get the problem sorted and get clear of that problem, and then go forward with good posture, good technique. And a lot of time these people have got that scapular weakness. They'll be sitting like that, their scapular control, meaning their lower trap, their serratus is not going to be too crash hot. So you may find you try and put them in this position, get them all right, but they can't hold it. So it may be something else you have to work on. With these people, I would always start them off. Did we get a foam roller? You're supposed to. Pretend this is a foam roller, okay? Get these people, before they do upper body work, if they haven't got great posture, they always sit down all day, get these people extending their thoracic spine before they train and when they go home and every day. Okay, so they're trying to extend their thoracic spine only with that. So if you imagine the foam roller is this way, okay, and get them doing that for a few minutes before your session. Get them loosening up. Thanks, Michelle. Because when you do overhead work or when you go past 160 degrees, you have to extend your thoracic spine to get that 180 unless you're hypermobile. Now, if you haven't got that thoracic extension, what are you going to do? Arch your lower back, or you're going to wind up your rotator cuff a little bit more, which is going to really put a lot of pressure through your upper trap muscles. We'll come to the rotator cuff one in a minute too. Okay? So these sort of people, don't get them doing bar on the back. You know, if they're doing pump class, get them to not use a bar. If you're getting them doing squats, get them doing front squats. Get the bar in the front, do it that way. But you actually have to hold your head back when you've got it like that. You can't put your head forward. Okay? And, you know, little things we teach people. You know, lie on the non-painful side. Get a decent pillow. You know, get that pillow underneath your neck. It makes a lot of difference to these people. Okay. Tennis elbow. Who in here has had tennis elbow? Oof. That's quite a few. That's about 20. All right. Tennis elbow is what they call lateral epicondylitis, and these days it's now called epicondylosis to a point. And I'll explain the two different things here. Tennis elbow is just called tennis elbow because it's a generic term. People with tennis tend to get it, okay? But it's a grip overload issue, okay? Number one thing, they're getting it because they're gripping too much and the extensors are going on fire too much. So, if you imagine if your extensors, I want you to put your hands out, flat, put your other hand on top of your extensors there. You should all know where your lateral epicondyle is, yeah? Okay, just come down to the muscle a little bit. What I want you to do is just close your fists and you'll feel those muscles work, right? Now, squeeze your fists and you feel them wind up. Okay? If you take your thumb away, it drops off a little bit. Put your thumb back on, squeeze harder. The harder you squeeze, the more they wind up. Why are they winding up? Because you're closing your fist, not opening it. It's because they're trying to fight these bad boys here. Okay, so your holders, your finger flexors are what's holding the bar, right? The heavier the weight, people tend to grip harder. Okay, now to fight that power through here, you have to wind up this. All right? So it's an extensor issue, and if they come into you and they say, I'm really tender here, they've got a tear in the tendon. It's gone past, it's not a muscle strain anymore. There is a tear sitting in the tendon. It might be minuscule, it might be quite a big one, but there'll be one there. And that pain will last for months, I guarantee it. How do you stop getting that point? Well, that's very difficult. They'll usually come and say, it's a wee bit sore there. Alarm bells when that happens. Okay, you've got to really try and make that not get it even worse. Because people just say, oh, he's a bit sore, must be training. That will then progress to a really nasty problem over a long period of time, because as soon as you've got it, it'll take months to get rid of. If they spend those months not doing anything about it, making it worse, imagine how long it's going to take to get them back doing proper weights again. So you've got to pick that stuff up early. You guys are got to pick it up, not me. I'm the one who's got the car crash. You've got to pick up that little pain straight away. But the tendinitis part is when the tendon inflames, because it's just getting overworked. It's tearing, it's getting overworked. What happens then, if they don't do anything about it and they keep loading it up, the tendon actually starts degenerating in structure. So they go through the initial pain, it starts settling down, they sort of rest it for a bit, they don't do anything about it, they don't do proper strengthening for the tissues, and the tissue is just getting weaker and weaker and weaker. It's like an Achilles tendonitis. They've only had Achilles tendonitis and then they've gone and had it snapped. It's just the tendon is just decreasing in volume inside the tendon, that you're losing amino acids and all sorts of things. So it turns into what they call tendinosis or tendinopathy. And that's just a dysfunctional degeneration weakness. And they're so close to fully rupturing it's not funny. But they don't feel too much. These are the really hard people because everything they do, they'll pick up a coffee cup, oh, that hurts. You know, little things hurt. Little tiny things, oh, I can't do that. It's so weak that lifting something hurts. Okay, those people will take about 6 to 9 months to strengthen that tissue up very slowly. What you guys understand, you can't go back to gripping straight away. And you might think, oh, what am I going to do? You know, how am I supposed to lift weights? Open palm grip. Okay, whenever you push something like that, do it open palm, so you're not using your extensors so much. Yes, the weight will have to be lighter, but it's got to be lighter anyway because it can't handle anything heavy. But when you press, that force that goes through the arm will actually strengthen the tendon as long as it's at a threshold below what the tendon can handle. Yeah? So you shouldn't have any pain with it for a start. And it's got to be, you've got to think this is going to take a very long period of time. Everyone's a little bit different, depending on how big the tear is, especially if they get a scan on it. So you consult your physio on your time frames of how long this thing is going to take. Because a lot of the time, remember, they don't feel too much pain until it's too late. So you may sort of go off the track a little bit and start gripping and doing things, and then the pain comes back and you've just wasted all that time. So be guided on that one. How does it cause? We talked about the gripping thing. So if you've got someone who's clicking on a mouse all day with bad wrist form, you know, click, 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 click. If you guys done a presentation or had to get an assignment in time and had to type how fatigued you get in your forearms, imagine somebody who does that all day. They do get used to it, but there's still a level of wear and tear there. And then they play golf and they're doing heavy weights with you. Okay? It's not just what they're doing in personal training, it's these other things that lead up to this as well. That's you've got to be aware of. If you've got a golfer who works in an office and types and doing lots of weights, they're more likely to get this sort of thing. Okay? And trust me, if you try and tell a golfer to stop golfing, he's going to bite your head off. Okay, open grip, we talked about that. Other things to think about is their training regime. These days, if you came in with the tendonitis, I'd probably shift you, knowing what I know over the last 12 years, shift you straight to a sports physician and start getting you on some nitroglycerin patches or corticosteroids if you were someone that needed to play, you know, high-level sport, that sort of thing. Get it sorted early, straight on a rehab program, not waiting around and let's see how he goes sort of thing. Most of the time we do be quite conservative. These sort of things these days, you know, ship them in. However, if it's a tendinosis that's gone past that stage, they've had this tendonitis for 6 months, those things are not going to do any lack of difference. It's the strengthening that's going to make the difference. Correctly, yeah. Right. How are we going? Okay. Same sort of topic. Is anyone here had a hamstring strain in here? Groin strain, that sort of thing, quite common. Again, these sort of things is tearing of the muscle, obviously, all right? But recurrent ones or groin strains that shouldn't be happening is usually a breakdown or an overload and breakdown of the tissue over a long period of time. Unless you slip over at a football match and tear your hamstring, that's different. Probably won't happen again unless you slip over again. Okay? But people who are doing running and getting a hamstring groin problems, so they're straining their groin after a while, geez, this running is really hurting my groin, that's an overload issue. And if it's happening over a long period of time, that tissue's overloading and inflaming, it's degenerating, yeah? It's getting weaker, it's starting to turn into this tendinosis, and so little things tick it off. They get to the point where they used to run 10K, now they can only run 2K before it comes on. So there's less aggravation now causes their pain. Why does this one happen? Let's have a look. Okay. Most of the time, it's your underactive glutes. Do you want to jump up here? This is the same sort of thing as hip flexor strains as well. We'll come to it in a minute. Most people, and they've done studies on people who have had hip groin problems, that sort of thing, so hamstring tears, 9 times out of 10, this is to blame. So their glutes or their lateral rotators or a mixture of the two are not firing correctly. So when they're doing their running pattern or sport pattern or squat pattern or lunge pattern, what they tend to do is compensate in other muscle groups that shouldn't be doing those jobs. Okay? So if you ever turn around and face this way, best way to test this, if they stand on one leg and they do that, instantly, you don't prime them, they just stand on one leg and drop the pelvis, you know you've got a significant pattern weakness going on that they just cannot hold their hip up. They can probably correct it, but they're probably going to be using other muscles to try and lift themselves up. Right? So if you've got someone like that, that's going to be weak gluteal stabilizers. Yep. Usually the primary cause of why the hamstring and the groin have to try and hold the hip a little bit more because these boys aren't doing it. Yep. So when you're going to train someone who's got weak problems like this, you need to address that, or they will start getting their little niggle when they run. They will start getting their little hamstring niggle. Or if they've got someone who's had these problems in the past, check this out. So if you're doing a medical history, which you all should be doing when you assess someone, their first time, what have you had? Oh yes, I get a sore groin every now and again, I pulled my hamstring last year. Check this out. This is probably still bad. If that's still bad, what are they going to get again when they start training with you? Another problem. Yep. And most likely inside that tendon is still weak. So their groin, their hamstring is still weak. And so the other side might be awesome because they love staying on that side. That's awesome, that side. But their weak side, if you start training something bilaterally, that's when they start getting a problem. Okay, cool. Check these people out too for their lumbopelvic speed. Most people with weak glutes are not great in their inner core either. Okay, so they're not very good at knowing where their neutral is. They tend to brace and use their outer core and they have no idea what their pelvic floor and their TA and their breathing is doing. Okay, and you cannot get your glute going automatically unless this is on. You can cheat and have it going and clenching and everything looks good and I can hold that and exercises are great. But those are the people you've got to watch because they look good when you train them and then they go out and do everything badly. Or they go for a run and it's happening. So look at that as probably a primary cause. And these people get weak glutes from all sorts of things. Okay, they might have an old back problem that they strain their back and it put pain at their glute and their glute switched off. They might have had a bit of hip arthritis. Okay? All sorts of little things can actually switch those off. Might be dominant one side, left versus right. Okay? These people are also quite hard too, and that's where your physio definitely come on board and try and teach that person their firing pattern technique. Okay, to making sure that muscle actually starts firing well, and they need to do a lot of repetitive, boring stuff that may be a little bit out of your field. So make sure you get these people, if they're just one of these people who just got a lazy bum and nothing's working, okay, or their hamstring, they just can't work. A classic one is someone who comes to a hamstring problem, they can't do this very well. They can't do that rapid fire movement. It's sort of going, oh, I can't really do that, because their brain is just switching off and not wanting to know. And they're going to re-tear their hamstring when they start doing sprints or step-ups or jumps and lunges and things. Okay, so like we said, check their posture, check their stability. Okay, what are they doing with their TA? We're going to come to our TA multifidus in a moment, but you've got to get rid of this pattern of hamstring and groin doing all the work. Get these ones doing all the work, and everything else second. And again, some of these people are getting it just because they're inflexible. They'll get a groin problem when they run because they just don't have very loose hip flexors. And they just strain it. Okay, they'll strain their groin at that point. Or they're a kicker, footballers. Because they just don't have the flexibility. Okay. Now this one is in yellow, just to remind me. This session is a whole hour and a half tomorrow morning, if you can make it, because it's such a big topic. It's only number 5 on our list because it doesn't happen that often when you're personal training, but it can happen. I've got that in there. You'll see on number 1 is lumbar strain. These two things are different. Lumbar disc. I've got a great video that I'm going to share with you just to give you an idea in your head what happens with a lumbar disc for those who sort of not too sure about what is going on with the lumbar disc. So just bear with me. Boo. I love YouTube. Okay. So, we're talking about lumbar discs, right? It is like a car tyre with a big jelly donut in the middle. Now, when you are jumping up and down, it's like a shock absorber. So you imagine this big, nice, really firm ring around this jelly stuff in the middle. When you jump up and down, it bulges and moves, bulges and moves. It's supposed to do that. Over time, if you spend too much time in flexion, bending forward, lifting forward, sitting down, it can actually, the pressure on the front will migrate the jelly fluid inside the disc to the back and push that back wall of the disc out. Now, bulges sometimes are fine. A lot of them, half the people in here probably got one, but you don't feel it. But when it gets so big, like that, it starts causing a lot of pain because the back of the wall is full of nerves. If it bulges right out and starts prolapsing, it'll hit that spinal nerve root and shock pain down the leg. That's your sciatica. So when it hits there, it just goes zap down your leg. But usually people are painful before that point. If that goes any further, I'll just, sorry guys. But I'll talk about this a lot more tomorrow. If that goes any further and starts, the wall of that disc ruptures. So if you get to this point here, that wall of the disc is ruptured. It's got so weak over time and it's ruptured. That material is going to come out of the disc and into that vertebral canal and then stay there. And you've got major problems at that point. They're off training. Most people are like that and it bulges out here. Most of them go for surgery. Some don't, but most of them go for surgery just because there's so much pain and they can't do anything. What you've got to realise with these people, if you've had, you've got to screen these people when they come in. Have you had a disc problem? Okay, oh yeah, I had a bit of a sore back. I think it was a disc. The physio did say it was a disc. Yeah. Hello? Those sort of people, you've got to really rapidly change a lot of different things in their program to stop that happening again. Because most discs recur. Okay, it's a degenerative process. So everyone gets disc bulges. Just some are asymptomatic, some are painful, some are really, really bad. You can try and prevent them happening again or making that one worse by doing a lot of different things in your program and correcting what they're doing. Because if that gets to that point, you're not going to be seeing them for much longer. So why is this happening? Number one cause is your family. Blame mum and dad. Right? If your mum and dad have got a disc problem, you're most likely to get one too. Your heart's probably going to sink in the room a little bit today. But no matter how fit you are, how strong you are, how well you sit, okay, if you've got family history, you are more likely than the person next to you. All right? Because it's a degenerative process. It's genes. Okay? So if your parents have got bad discs, you've taken that on. You look like them. You look like them here too. Not maybe here, but in there. Okay? So it's a massive hereditary factors, and every study around the world they've done shows that the persons with the most amount of disc problems have a family history of it as well. Okay? So if your mum and dad have got a disc or your clients, parents have got a disc, you've really got to look after that client. Because at some point in their life, it's probably going to happen. If you can try and reduce the effects of it, great. Other things that cause it. You've got a family history of it. Mum and dad have got a disc problem. My dad has one. I've got to watch myself. Sustained periods of sitting. Luckily, I don't sit. I stand all day. Sustained periods because you're sitting, bending forward. You're not sitting in a good posture most of the time. You're loading up your disc. Even when you sit in a good posture, your disc pressure is higher than when you're standing. And there's a really good graph, which I'll show you people tomorrow, if you come to that thing tomorrow, of all the disc pressures. So if I'm standing here at 100% disc pressure, when I sit down, it's 140%. Even if I sit well. If I bend over and brush my teeth, it's 150%. If I do a deadlift with a decent amount of weight, like that 20 kilo bar, it's 220%. And if I sit down doing bent over flies like this, or if I tie my shoelace, that's 275%. And you don't feel it because they move and bulge. But someone who's got a degenerating disc, they're in that 30-year-old to 55-year-old bracket, They got a family cause, they sit down all day. This is how it happened. People bend down and do up the shoelaces and bang! That wall gives that final little nudge and prolapses. Things that you can affect, the loss of neutral. So when you're squatting, now this can be extension or flexion. When you're getting that person squatting and they start going to this extension like that, they're losing neutral. They're not going to flexion, but they're losing neutral. And when you lose neutral, you lose your core stability. So your TA will switch off. Okay? The less support you have around the spine, the higher the pressure. Okay? So if I go down, if I start rounding out, if I go too low on my squat with a heavy weight, again, that's going to give me more disc pressure problems. People sit down all the time, they're more likely. So someone who is fit and healthy is obviously not going to get as much disc pressure problems as someone who sits on the couch all day. And watch your mums. Very high rate of disc prolapses after childbirth. Why? Yep. Ligament laxity, and their core is most of the time, 95% of the time, not as good as what it was. So they are at a disadvantage. They don't have the support going on there. And what I mean by core is transversus, pelvic floor, multifidus. Yeah? Those are the ones close to the spine. They're going to switch off and lose your support. Then all they rely on is their outer core. Previous trauma. You've had fallen off a horse, broken your coccyx. Probably most likely going to get a disc problem after that. So watch these people. You've got to be thinking, everyone who's come in with a previous disc problem, they're good now. But they've had a previous disc problem, you've screened them, McKenzie extension. Okay? Get them, every time they come in to see you, and the first thing they do is they go, gee, I've had a hard day, let's do this. Okay? You reverse that posterior disc pressure back away from that back wall that they've been doing sitting all day. This is awesome. This is a gold standard stuff. Okay? It's a little bit different the yoga one. You're trying to keep your hips down a little bit more. You're trying to breathe out and relax. Okay? Only going up to where the tightness is. And you can see with Michelle, she's got a disc problem. Her extension isn't quite that crash hot, is it? Okay? She's lost a bit here. So this point here, she should have a better curve at that point there. And how many years have you had? 6 years. 2 prolapses in 6 years. And she's fit and healthy and awesome trainer. Okay? I'll blame mum and dad for that one. But she lost her extension. Does she have to get that back? Yes, she does. Why? Because we need our extension with everything we do. If we don't have it, we sit there and we can't reduce our disc pressure from sitting so much. We tend to sit with more flexion if we don't have our extension. Okay? So you've got to try and get that back. You've got to re-educate these people with neutral. Have a jump up. Facing this way. I won't spend too much long on this, but this way here. They've got to be educated on where their neutral is for a start, and then to try and maintain that when they squat. Maintain that when they bend down and do a normal deadlift. All right? So these people here, you can see she's got a little bit of extension going on. Can you see that? Yeah? Another thing you've got to remember, which we talked about today, is when you see a spine and you see that lumbar curve, don't try and mimic that with your body. All right? The lumbar curve is sitting in a curve inside your body. It's filled up with muscle. So don't try and have a nice curve here and think that that's neutral. Neutral is actually nearly, not flat, but her neutral is about there. Okay, let it go. Bang. She goes back into there. So if you think, you can't think about a spine as your neutral. You've actually got to come back, and because the muscles on your back fill up that little bit of curve, so it's less of what the actual spine is. Does that make sense? When you see it on a body. Okay? So make sure when they squat, if you go through a squat for me, she's learning now. See how hard she finds that? Yep, to try and do it properly. Come back up again. I'm going to guide a little bit more, feed apart a bit more for me, Michelle. Okay, so she needs to get a neutral first, and she needs to keep that on. Now at that point there, she needs to hold her transversus on about 30% of 100. Okay? And then she needs to breathe in when she drops down. So breathe in when you drop down. And I'm just going to go to sit your bum down. Sit your bum down. And I have to actually correct her to that point there. So she doesn't really know it. She wants to go in extension. And then when she pushes up, she's got to breathe out. And that pelvic floor needs to lift internally. And she needs to keep that neutral. So I had to push her back into a bit of posterior rotation because all she wanted to do was do that. Because she's so used to being extensor dominant here. She's so used to going, that pattern of movement, yeah, let's extend my spine because that's where my strong muscles are. Unfortunately, she loses her core every time she does that. And it's not helping her disc problem. She's not getting it right. Yeah? Okay. So these people, you've got to re-educate. They've got to re-educate when they sit. Okay? I want you to do all this for me now, just so you've got an idea. If you all sit there and you just slump down, it's like you've probably been doing the whole time. Put your fingers in here and you feel your soft, gooey abs going on. We all have that when we go into flexion and out of neutral. So I want you to come all the way into a ridiculous amount of extension and then go all the way back down to a ridiculous amount of flexion and try and find your midway point between the two. Yep. Good. Now, the back of your head, I want you to go a little bit taller, so you're sort of taller than your person next to you. All right? Sit your shoulders down a bit. Good. Now, put your finger back in here. What's going on? It's all working? Yep. So as soon as you go into neutral and you adopt a neutral posture, your brain has an automatic response to switch that on. Therefore, when you train and you keep that person neutral, you will keep that TA working and you'll keep that inner core going. As soon as TA goes on, multifidus is on. Yep. Now, at that point there, I'll talk about this perhaps in our last one. We're going to teach you breathing. Just remember that. So I want you to try and maintain that posture for a little bit, but sit on the back of your chair. These chairs aren't so great. They sort of tend to tilt back. They need to be a little bit more upright. But see if you can keep that little bit of posture there for me. Only with disc pressure problems are you not allowed to do Romanian deadlifts. Okay? Just get rid of it. I don't care how strong they are. Get rid of Romanian deadlifts for disc problems. Okay? People who've had a disc problem, don't do Romanian deadlifts with them. Loaded flexion, 220%. Okay, it doesn't matter how strong you are, you still cause 220% loading pressure. If that disc is degenerated, lost height, lost all its fluid, it's just going to give you grief. Okay, so get rid of that. Get rid of seated flexion. You guys probably wouldn't be doing seated flexion anyway, but if you see people doing it, who are your clients, you know, they've got to be told. Common rule. Take home message if you take home anything today. People with disc pressure problems are not allowed to do more than their body weight and a squat. Okay? So if you're 80 kilos, you cannot do more than 80 kilos as a common rule in your squat. Most surgeons say no axial loading whatsoever after a disc prolapse. So you've gone in for a discectomy and had disc surgery, they then say no axial loading to the physio. But, you know, axial loading is in life. You're going to carry something to one there, you're going to carry it. What they mean is don't do heavy squats, is what they're trying to say. Axial loading, so don't load pressure down because he's not going to handle it. The person's going to get back to normal function, but if you start loading them up again to try and get them stronger, it's not going to work for these people. And like I said, these people are going to come back in the door 3 months later with another one if you don't look after them. All right, these are very, 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 very common. Mostly in females, yes. Just the weight. Yep, yep, yep. No Romanian ones. The modified, just the normal one? Oh, this? Yep, fine, because that's exactly how you pick up a bag of washing. Yeah, absolutely fine. And tomorrow you'll see they have to be trained how to do that deadlift properly because it's a functional movement pattern. Because otherwise, if they don't learn that deadlift, they'll go, I'll pick my bag of washing up. And that's the Romanian deadlift. Okay? So they have to learn how to do this thing. And I hate this. We do have sumo squats in our Rehab program, but who does this? To pick up a bag of washing. You know, they say bend your knees and do this sort of thing and pick it up. No one does that. They do it this way. They always go for it. They don't get and do this sort of thing because they usually don't have the range. All right? And if they don't have the core to do this, they'll just go and hinge forward. All right? So teach them normal deadlifts and normal squats is a good thing for these people because it improves their patterns of movement in life because they get stronger, they can do it more often. Okay, hip flexors. So females. Why females? Anyone know? No? Sorry? Anterior pelvic tilt? Yep. Okay. Does anyone know the difference between quads and hamstrings in females versus males? right? Relatively got smaller hamstrings, females. Once they hit puberty, their hamstrings tend to sort of not do too much. Their quads tend to grow more, whereas males are sort of standard ratio. They did a test in the New Zealand Olympic team about why people are getting, problems, hip flexors, all that sort of stuff, anti-cruciate ligament tears in females, and they worked out it's their hamstring strength. And they did a massive study, and females, when they after they hit puberty, boys and girls are the same. Once they hit puberty, females' hamstrings are not as strong as their quads. And you'll notice this when they jump, because females will land and jump like this and go, and that's how they land most of the time, unless they're an athlete. Males will land like this and squat, okay? Because their hamstrings are stronger and can take the load. And when your hamstrings are stronger, usually your extensor mechanism is better and your glutes are better. Okay, when your hamstrings are a bit weak, you tend to go into an anterior pelvic tilt and you lose the ability to fire this one because you lose your neutral, yes. Think of it as like 4 to 3. Yep, 4 quads, 3 hamstrings. General rule, but don't quote me on that. Okay, but females will just have generally less hamstrings. You train those females' hamstrings, they'll get less hip flexor problems because when they run, they've got more drive here. Okay, they're better. Hamstring is an extensor of the hip. It's the major extensor of the hip. Okay, they've got more drive. So when they run forward, they don't have to lift their leg forward as much. So if people have got less push power, they need more pull power. So they start using hip flexors more often. So rectus femoris, iliopsoas. Okay, they'll use that more to lift their leg forward. Okay, they'll also use it as a stabilizer if their glutes not working. So if they're doing this sort of work, and they're dropping, they'll start using the hip flexor as a method of trying to stabilize their hip and keep their hip strong because this one's not working. The brain's not good enough to say, oh, I know what the problem is, let's switch my glutes on. Okay, it doesn't do that. We've got to train it to do that. Again, lack of rest. These people don't rest enough to settle down the front. They go and feel fine when they walk. They go for a run. They haven't fixed the buttock. They go and re-tear it again. It's very common to get these people back and back again. My hip's playing up. It's so sore. I've got a friend of mine who's got a hip flexor strain. It's been going on a year. Do you think that's a tendonitis or a tendinosis? Tendinosis. Why isn't she getting better? Because it's just so weak in there. Okay, and she's going through all this trouble of trying to get it strong, and it's taking her a long period of time. And a lot of these people underlying that, if they get all this problem in the front, they start getting weak here, they start getting joint issues, and it just starts escalating. Okay, what are you going to do with these people? Underactive glutes. If I didn't show it too well, I'll show you exactly what's happening with this person. Can you see that? Left hip dropping down. So when you see people do this, you should test your clients on this. They've got pain in the front of the hip when they run, get them up, get them doing this. If they're doing that, they've got weak stabilizers here. Okay, he's got no arse, this bloke. Okay, but weak stabilizers, you find that people with no glutes have no arse. And they think, oh, fit in my jeans, You got no bum. They need a bum, otherwise they don't get rid of this problem here. So this person here needs to work heavily on getting the stabilization. Can you imagine if he's doing that on one leg just like that, what is happening when he lands it or when he runs? Okay, there is more activation when he runs, okay, but he basically will end up tearing that quad again, hip flexor again. Okay. This muscle re-education firing patterns, massive, massive one. Very hard to get glutes going. How hard is it to get someone's glutes going, right? Okay, you might fire them, but then they don't do it properly in an automatic pattern. It's very hard to get that brain switching back on. Send them to the physio. They should be able to sort that out for you. And a lot of people, no one ever checks what they do when they run. Get them on the treadmill, have a look at them. Are they running on their toes? They're more likely to have hip flexor problems if they run on their toes. They're not getting the landing stabilisation and their glutes firing when they land. Okay. Okay, this is the big three now. Yep.
You're saying you should actually go to heel.
Yes.
I read something recently that said that you should run on knee and hip.
Right. Sprinters run on their toes. Long distance runners run on their heels. Bang. We walk like that. That's how you should run. Sprinters need a hard platform, so they have to run on their toes because they've got to put a lot of power through from the ground reaction force. They need a lot of power, a lot of drive. They land on their heel. When you land on your heel, you pronate, and it's like a shock absorber. It slows you down. Okay, it slows down the ground reaction force. So there's not so much shock going through. Okay, so that's why you land heel toes, to decrease the shock loading. Okay, get all these muscles working properly. But when you're a sprinter, you have to run on your toes to keep a rigid supinated platform foot to push you along, but they only last for so long. Okay, but no, you've got to land heel toe. There was that, I think, was it the London Marathon? Did you see that woman who ran on her toes and won the whole race? You ever seen that? She's a freak. But don't try and promote it. Try and change it if you can. Okay, if they're having problems. Yep. Some people don't have problems. You don't have to change it. But they're having problems. They're running on their toes. Get rid of that. Okay, big three. Rotator cuff. Who's got a client with a rotator cuff problem in here? Yep, quite a lot. Impingement. Classic scenario. They'll go, ow, and then come through it. Or it's pain all the way. Okay, and they've got a funny movement pattern going on. These people, impingement can come from rotator cuff tendons. It can come from the bursa sitting above the tendon, below the acromial space. Okay, so it might just not be the rotator cuff, but usually the rotator cuff is involved. Now these people, tendinitis, the same issue going on here. The body's very simple, same processes that go along. Okay. What you've got to look at these people is repetitive weights overhead is probably the primary cause of this. Doing this will cause you rotator cuff problems because they're in a close packed position. Okay? If you look at your anatomy, that glenohumeral joint on the end of that humerus, okay, on the ball there, they've got a tuberosity where all the tendons attach into. When you go into this position here, it approximates right up to the top of the acromion and sits right underneath it. Now, if your acromion is sitting forward, or if you're very, very tight in your rotator cuff, or very weak, when you move, most of the time that tendon will get caught. Okay, so if you think a tight rotator cuff is usually a weak rotator cuff, tight is usually weak, right? And if you're in this position here, and I've got a weak rotator cuff, my rotator cuff's job is to assist the movement, but also to keep that ball rolling perfectly in the socket. Now, if it's not rolling perfectly, it'll get jammed on the way through. And I'll give you an idea. If you've got someone with a bit of poor posture, you guys sit down for me, back into that bad posture that you're in before. Okay, imagine you're sitting in a shoulder press machine, which a lot of people do. You may not be doing it in your personal training sessions, but a lot of time people are doing this outside of your sessions. Come up into this position. Most of you find it quite hard to actually hold your shoulders up in that position when you are sitting badly. So let's sit up a bit better. Yeah? A bit easier? Now, if some of you are like this, you've got a tightness issue going on there. Okay? You should be at 90 degrees. Okay? I'm not quite there. Right? Some of you might have a stiff thoracic spine, you can't get that point. Or you might have an old rotator cuff problem or something like that. I want you to force yourself into 90 degrees and get yourself there and hold it there. Has anyone saw you? Hands up. I'm just kidding. Okay, now I want you to press up to the ceiling. Does that hurt? Okay, hands down again. How many people did that hurt? Quite a few people. I guess you're shaking your shoulder, okay? So those sort of people, you've got to be thinking, is it their shoulder posture? Okay, is their scapula forward? Am I thoracically kyphosed? Have I got too much tightness here, that old swimmer's stop sign? Can they get back to 90 degrees? If they can't, they shouldn't be doing overhead pressing. Okay? Or you try and get them better at that and then return to that. But also these people, other factors. Overhead tasks, painters, people, labourers, people doing things above their head come and then do shoulder press with you. And they've got one shoulder that's weaker than the other, one shoulder that's tighter than the other, right? And they start getting problems. The other big one is gleno joint instability. So we've got the tight people, but a lot of times the people who are hypermobile that have the major issues because their ball is rolling around the socket like this and they're pressing and it's not doing perfect movement. Because most hypermobile people in their shoulders haven't got great rotator cuff control because they don't have the stability of all the ligaments holding that joint together. Yes?
In terms of hypermobility, I'm not sure, but a person that is hypermobile, they tend to be hypermobile in more than one area of the body.
Most of the time, yeah, most of the time. Very rarely do you get someone who's got, look at my wrists, and then everything else is tight. Okay. Some people will have, most of the joints will be loose. There's different degrees. There's this scale which goes from 0 to 9, and it's a hypermobility index, and it's like thumbs down, do they extend at their elbows, can they bend forward, do they lock their knees, that sort of thing. Most of the time you'll find that some people there have one thing that's not hypermobile. There's a bit of a rarity, but 9 times out of 10, that's everything. You know, they'll snap their knees back and that sort of thing. Okay? It's a general laxity in their joints. Age too. People who are older will more likely get rotator cuff problems just due to the wear and tear. Now, if we have a look at this, this is what I mean. When you guys as trainers are watching people, you know, pushing the trainer, you've got to be seeing if they do this. Because if they do this, they've got rotator cuff impingement. Can you see that? Why is she doing that? Yeah? Why? She's lifting her scapula, right? She's using her upper trap. Why? Compensating for, a lower trap will be turning off. But what's she trying to do to get that weight up? What's she run out of? She's run out of range in the joint. She's gone up, and that ball has hit the top of the joint and gone, can't go any further. I'll have to lift it up a little bit higher to get there. Okay, so it's a natural reaction to try and get that up. Watch that one. Same with the pull down. You'll see, notice that they pull down and they'll go like that when they come up because they can't get that synchronization right. And things you can't control, bony encroachment. When they've got actual bony wear and tear and bits of bone growing inside their joint, you can't really control that, but you can see the causes for sure. Guide their patterns. Avoid your shoulder press. Yep.
You mentioned the last pull down. I actually noticed that one of my clients was doing that only this week.
Yeah.
And I was kind of standing there going, that's not right, but I wasn't sure.
Yep.
So should you just make
Well, it could be because of pain or like a stiffness. You know, they feel a bit of pain they're not telling you about. Or it could be a weakness they've got. They're developing a switching off effect in that serratus, and that could lead to this sort of thing. So you need to make sure that they get assessed on why that muscle is not working properly, get the right exercise to correct that before it becomes a problem.
So I should probably, if I notice something like it was quite...
Yeah, if you notice something like that looks abnormal, get them assessed, see what's wrong with it, because otherwise you might keep doing it and then all of a sudden, hey, my shoulder's sore. And you could have prevented that. Closed chain with these people. I did a workshop on this last year, but closed chain to start with, moving to open chain. And you've got to go through a very strict rule of advanced strengthening to get the person being able to lift above their shoulder again, because that rotator cuff has got to be spot on to be able to get that ball and socket working correctly. Yes. Best one is just press-ups. Yep. Just push. I call them press-ups. Must be from New Zealand. Push-ups. Yep. And then you can advance. You know, if they've got rotator cuff stuff, we get them doing very, very low-level work. Okay, so getting on learning how to actually get their serratus working and stabilising. Okay, getting to that point. Then going to a sort of semi-push-up position, full push-up on a Bosu, and then starting to do some open chain. Very light work. Above head stuff is, once you've got them pressing like that and pulling well and rotator cuff working, then you start advancing above the head and you start going in a diagonal position up to there. Okay, so they get using their deltoid and their supraspinatus into that position, getting their scapula working, because that position is the start of a shoulder press. So if they can get enough strength to get their hand up to there, they should be able to start from there and then press above. But from that position, we don't go to the shoulder press there. We'll come into a front press. Get away from that close pack position into here, where your humerus is not going to hit the top of your acromion, and you slowly move out. And that whole time, by the time you get to here, you should have got their thoracic extension better, you should have got their range of movement better, their posture better, their core better, so they can actually hold themselves in that position and do a really good shoulder press. Yep. But recurrent people get recurrent rotator cuff problems. We just say get rid of this shoulder press, stick with this one. Yep. Because it's a functional thing anyway. You put something in the cupboard, you don't put it up in the cupboard like that. You put it up in the cupboard like that. Yep. Okay. Patellofemoral pain. Who's got patellofemoral pain in here? Who's had a client with knee pain? Ooh, it's good that it's number 2, eh? Okay, patellofemoral pain, meaning patellofemoral, right? Pain in the anterior part of the knee, front part of the knee. Comes from a lot of different structures. It's bagged up into one big thing called patellofemoral pain. So we're not talking about meniscal tears or cruciate ligament tears or anything like that. It's just generalised pain in the front of the knee. Can be sharp, can be achy. Okay? Most of the time, it's sitting 2 areas. Bottom of the knee, just to the outside there, and right on the outside here. Okay? Third point is in the top of the knee. We'll talk about that in a minute. Bottom of the knee, under here, is that infrapatellar fat pad. So not a patellar tendonitis sitting in the middle, but off to the side. That little, oh God, it's really sore in there, and that's aches after running, that sort of thing. Sitting right on the side there. Very classic after squatting. This one here on the right side, the ITB issue. Yeah? And the top one is your patellar surface problem, a fat pad impingement. So basically what happens, I mean, this is one of those things that can start anywhere in the cycle. If you've got repetitive joint loading, you're doing a lot of jumping around, a lot of running, a lot of squatting, playing a bit of basketball, yep, jumping on and off a garbage truck, then you basically irritate some of those structures that sit underneath the kneecap and around the kneecap and around the joints. And maybe that you've got a bit of a weak leg anyway, okay, you're not sort of muscly in your legs, you're very tight here, very tight glutes, glutes are a bit flabby, okay. You'll start causing biomechanical problems in the knee if you load it up. So usually these people start with a bit of a biomechanical problem, then load their knee up. Causes pain inflammation, that crepitus is the creaking, the noise you hear, or a crunching noise you hear. When all that's going on, your VMO just switches right off. So pain, inflammation, noises will switch that off. So if you find most people you've got a painful knee have a rubbish VMO. There's hardly anyone I've seen who hasn't got, even if they've got a good VMO, look bulky, it's deactivating, it's a bit squishy. It may look big, but it's squishy compared to the other side. That'll switch off, your body will compensate, switch on your lateral structures. So your lateralis will start going, way, let's get into it. And that starts drifting your kneecap off to the lateral side a little bit too much. So it starts not coming out of the groove, but riding to one side and stressing out structures underneath the kneecap, like your fat pad and your bursa and the cartilage on the inside of your patella. Switches this off, your glutes destabilise. So VMO's going off, pain's going on. Next thing to go, the body starts switching down your glutes. So these people will squat and do that. So they'll squat on one leg, their knee will roll in, and they'll drop their pelvis down because they're just losing all their control, which heightens the problem because they're losing muscle control now, which means when they land, the shock loading through the joint is higher because their muscles aren't absorbing it. Yep. If it's painful, yes, but most of the time, and most of this happens in females' crunchy knees, yeah, and they're very concerned about it. Most of the time it's going, if it's making a noise that you can hear, okay, it's a vibration of grooves in the cartilage of the patella. So they spend a lifetime of wearing away that cartilage and putting grooves in it, and the vibration is what you hear. They usually call that chondromalacia patellae. That sort of stuff really can't be fixed. I was unlucky enough to bust my anterior cruciate last year, and I've rehabbed that, so I've gone through this whole phase of getting my VMO going and anterior knee pain and the whole nightmare after surgery. And when he went in there, he saw I had this big groove and I had a creaky knee upstairs. Every time I go upstairs, creak, 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 as I go upstairs. He went and cleaned it up when he was in there, saying, no, I just cleaned up your patella, by the way. So he took the groove out. Now when I go upstairs, this one's creaking, this one does nothing. Okay? So can you go on and do the other one? Oh, I don't really want surgery again. So it is a wear and tear issue on the patella. If you've got people like this, and if you've got IT issues, that sort of stuff, you've got to fix all the problems that are going on. Okay? You've got to stop them letting that knee roll in when they do a squat and a lunge. They've got to get... Do you want to jump up, Michelle? They've got to make sure when you're training them, if you keep letting them let their knee roll in, if you keep letting their pelvis drop down, they're going to keep accentuating this problem. They're never going to get strong in their VMO. Let's go into a lunge for me. So, person who rolls, they'll go into lunge, they'll drop that knee in. Yep? Weak lateral rotators up here. Okay? They're never going to get good VMO if that knee goes out of line. Alright? If you turn and face the other way. When they also lunge, their pelvis has got to stay level. Okay? So if their pelvis drops down one side, that's weak here. Okay? If you're weak there, when you land, you're never going to have good control of your knee. If you imagine, thanks Michelle, if you imagine my centre of gravity, when I land on one knee, if I roll that knee in, where's my centre of gravity now? Through the outside of my knee, through my ITB, bursa, okay, through my fat pad, out here. Okay, so it's usually where that knee rolls in, and the VMO is always to blame as well. I'll show you a tracking issue. You're going to see my colleague's knee, and you're going to see my knee. And I've rehabbed my knee, so my knee's not too bad. Where is it? Yeah. Okay. Okay, this is my colleague's knee. She's got a decent VMO tone, that's okay. What you're looking for, when you squeeze your quad, your patella moves up towards the head. So this is the foot down here, head up here. Sorry guys, I'll just show you that again. I'll just pause you here. Oh. Okay, this kneecap here, on a normal movement, goes north and a little bit lateral, Okay, so when she moves, you'll see that. When she squeezes her quads, did you see that? North, a little bit lateral. It might be hard to sort of see for you guys if you haven't sort of watched someone squeezing their quads very much. You watch me squeeze my quads. Now this is my rehabbed knee. My VMO tone's back up to normal, but I'm still stronger out here. So you watch my kneecap drift off to the side. Can you see that? Now if I go for a 40-minute run like that, which I've been doing, do you reckon I'm going to get a wee bit inflamed in here? A bit of wear and tear. I've got to work so hard on getting that balanced up. Okay, something you can look at with your clients. Okay, last but not least, back strain. I know we're running out a bit of time, at least with the last one. We can all go for a beer soon. Your back strain. This is the classic one where people will go, I strained my back. Oh, it's a bit sore. Yeah, it's really tight in there. Oh, God. Oh, and I try and stretch it out. How many people have got clients with a bit of a back strain? Okay, so that's the most amount of hands we've had up today. Now, these people may or may not have a disc problem. What I'm trying to focus on today is why most of them are getting this issue, and it's an extensor overload. Okay? We're going to talk a lot about this tomorrow, in our session tomorrow. Extensor overload meaning your spinal erectors that are sitting there that feel great in there, okay, big suckers in there, they're doing too much work. Why are they doing too much work? Usually because they've had a previous little bit of a back strain, or they haven't got good core, or they sit too much, or their posture's no good. Okay, and they overload their extensors. Now, if you've got say you've got an old little bit of a back pain and you've deactivated a little bit of multifidus at that level, what will happen is the body will compensate. It's not clever enough to switch their muscle back on, the little ones, It goes, we'll use the big boys because they're big and strong and we'll use them. Unfortunately, those extensors are designed for one movement and off. Okay, your multifidus, which is sitting in there, which is your stabilizer, is designed to be a muscle that switches on all the time. Now, over time, if that muscle's not working, your extensors will start taking on that role and becoming a tonic muscle, which doesn't work. They're not designed for that, so they fatigue really quickly. Yeah? They start getting tight, trigger points start getting sore, you start getting inflamed, things start getting worse. Now, for these people, oopsie, it's usually their incorrect breathing patterns. So, what happens is they tend to brace, or they breathe out when they should. They use their pelvic. They don't even use their pelvic floor, or when they breathe in, they suck their ribs up. Okay, or when they try and brace their core, they use everything. They try and hold their core like that and hold it on when they squat. Okay, when they're trying to use their outer core instead of their inner core. What you guys have got to remember is you've got to get these people breathing correctly. And I'll give you a little bit of a hint. While you're sitting there, this last thing we do today, go back into that neutral position. Find your neutral position. Remember, when you get your neutral position and your head's long, you're sitting well, your TA should be on. Okay, should be on about 30% normally. Some people have got a bit of back pain, it's probably a little bit lower. What I don't want you teaching your clients is to try and draw in that 30%, that TA. Okay, that's not what you're supposed to be doing. When you take a punch to the guts, you draw it on. Okay, but to try and maintain neutral and get your breathing right, you've got to just keep that transversus muscle sitting at 30. So you don't really have to think about it if you're in neutral. When the load goes on, you have to probably draw it in a bit, because when the load goes on, they'll start popping into a little bit of extension or a little bit of flexion. But this is the take-home message for this one. When you breathe in, I want you to breathe in through your nose and fill up your lower ribs. Okay, you expand your lower ribs, not up into your chest. Okay, and don't let your belly expand because you're going to lose your TA. So your TA stays on, just here, stays normal. You breathe into your lower ribs. Okay, this is what they're for. They expand this way. When you breathe out, you have to slowly lift up your pelvic floor internally. Females will get this a little bit. Males will go, what are you talking about? Okay, for males, we need to try and lift up our scrotum off the bench. Okay, hold a pee and hold a fart at the same time. Some people might go, oh, I got that one. Yeah, hold a pee, hold a fart. If you guys, you both hold a pee, then you feel the front, hold a fart, you feel the back. There's two parts to it. Okay, so try and hold them together. You'll get that internal lift. For females, it's a little bit different. They can either use that or they can do an internal draw-in, which us males don't have. Anatomy is a little bit different. Okay, they may use that as a bit of a manoeuvre. So these people, you've got to teach them pelvic floor training because they've got everything around the wrong way when they're doing extensors too much. Okay, you can't just teach them to hold your tummy in. It's not going to work for them. So they've got to get their neutral and then work on their pelvic floor. Imagine that back as a cylinder. Okay, you keep the cylinder one, don't let it sort of go in and out. Keep the cylinder right and up and down works. When you breathe in, your diaphragm flattens out, your pelvic floor lets go. When you breathe out, your diaphragm recoils. What's got to come up? Pelvic floor. You've got to keep that pressure even. So when they squat, breathing in, on the way down. Okay? When you breathe out, it's got to be against gravity or against the load or on the exertion. Okay? So you don't breathe out here and then breathe in at that point there. You need all your TA and pelvic floor working when you load up. Okay? Because otherwise, if that TA switches off or your pelvic floor switches off at that point, you're going to use your extensors to get you up there. Okay? And a lot of you will try and find, if you practice this, you're going to have to drop the weight right down to actually get this going properly. Yep. If they're really bad at it, they've got to do it lying down. And if you look at, we've got to really finish up here, but if you look at this, one thing you look at as your clients is look at their tummy button. When they breathe in, when they breathe out, that tummy button goes north, like that, up towards their chest, they're bracing. They're not using their pelvic floor at all. Okay? What that belly button needs to be doing is when the pelvic floor switch on, your lower abdominals will switch on and it'll go south. And you'll see it going towards the left there. Okay, so when they breathe in, recoils back to normal. When they breathe out, gets drawn down. Check it with your clients. Lift their t-shirt up and have a look. Okay? Alright, so to wrap this up, what are you going to get them doing? Stretch out their QL and their extensors. When you do this, I want you to practice this today because you've been sitting down and standing all day. When they grab their foot and they do that, that's an hamstring stretch. They're not going to stretch their back out when they do that. You've got to get that knee right up to their chest, keep their shoulder on their chest, and then as they straighten, they've got to go with it. And then you'll feel your lower back stretching out. Once you get to that point where you can't really go any further, hand on thigh, push that hip down and turn around, keeping down, and then you'll feel what you probably haven't stretched for a long time, stretching out. Okay? And these are these muscles that need to be stretched out on a regular basis for these type of people. Alright? So try that one at home. Re-educate them on their inner core. Get their breathing right. If you do nothing today apart from get their breathing right, you're going to win with these people. And practicing that neutral, practicing that breathing, practicing when they do a body weight and a deadlift. Okay? Has anyone got any questions on that? No? Yeah? I'll stay here for about 15 minutes afterwards for any questions. If you guys, I'll skip that. If you guys have need those sets of notes on file, Google Physio Fitness, go to our website. Okay? There's a FILEX button. Click on that and download today's session. All right? If you ever going to want to get newsletters, that sort of thing, about images and what we do, click on the sign up for the newsletter tab as well. There's some more handouts at the back there as well. Okay? And if you want any questions about today, come up. I'd love to talk to you. Thank you.